Hi, good evening, and thank you very much for the invitation. We'll be talking about how neuropathy will affect plantar pressure. So basically, when we talk about plantar pressure, it's about the pressure on the plantar aspect of the foot, on the sole of the foot. I don't think I need to talk much about neuropathy and what a serious condition it is. Considering that almost half people living with diabetes are liable to get neuropathy, and when one considers that there are about 600 million persons globally living with diabetes, that is a very big problem, and it is, I think we will all agree, a serious problem because basically there's a high incidence of foot ulceration. And it is foot ulceration which are the first stepping stone, so to speak, to amputation. So basically, we know that there is a very big relationship between pressure, because obviously when we walk, we are pressing down on the ground, okay, or in the shoe. And we know there's a very big link between pressure and the formation of ulcers, because pressure causes callus formation on the plantar aspect of the foot, or blistering, and pressure and shear stresses often cause local tissue breakdown, which results in ulceration. Following this, if the ulceration is not managed very well, this will then lead on to even amputation. So, what can cause pressure? There are intrinsic and extrinsic factors that can cause pressure in the foot. So this increase in pressure can be from limited joint mobility, such as when you have conditions such as hallux limitus, hallux rigitus, functional hallux limitus, when you have ankle equinus, rigid feet, and foot deformities, such as when you have lesser toe deformities, hammer claws, hammer and mallet toes, hallux valgus, and even bony prominences. Then there are internal forces, for example, the shear between the skin, the underlying soft tissue, and the bone. Besides internal factors, there are also external factors, such as incorrect footwear. We all know that, like high-heeled shoes and narrow pointed shoes, or even loose shoes. So shoes which are tight, which are oversized, which are worn out maybe, which are incorrectly fitted. Then we can have trauma, knocks, and injury from foreign objects, etc., etc. So all these can cause an increase in pressure and increase in the risk that area where there is pressure will eventually ulcerate. Certainly, we need to do a thorough diabetic foot risk assessment in all, I should say, in all patients, okay? In order to prevent these diabetic ulcers, ideally, it's better to prevent the ulcers from forming than having to treat them. Foot deformity is high in diabetes. So this is one of our earlier studies where we were shocked by the prevalence of foot deformities, such as hallux valgus, claw toes, hammer toes, and like Julia was saying before, hammer toes, you know, they can cause pressure on the apex of the toe or on the dorsum of the toe. So these little, what could be considered as little problems, you know, can have devastating effects on the foot of a person with neuropathy. So when we do a foot pressure assessment, it's very important that we don't just look at the pressure map or how much pressure there is, but we also need to do a proper biomechanical examination of the foot. And so we need to look at each individual joint of the foot, because remember that with diabetes, there is glycosylation, which will cause the soft tissue to become stiffer, and so limiting the range of movement. But not only knowing that there is limited movement, it's also important that we know the range of motion of each individual joint, so that we can know from where this excessive pressure is coming from, and hopefully how we can manage it. So we have to check each joint individually, the ankle joint, subtalar, the mid-tarsal joints, and its oblique and longitudinal axis, the first metatarsal joint, the first metatarsophalangeal joint motion. We need to look for quality of motion, and most of all, to see if there is any rigidity in this joint, because that would affect treatment. This is a typical case that shows that we need to combine a lot of measurements, a lot of biomechanical insights that we have. Okay, so this is a patient with an ulcer underneath her first metatarsophalangeal joint, and had been like that for over a year when she was referred to us. And as you can see, there are clear biomechanical problems in her foot. Okay, so you cannot just try to offload the ulcer, but you need to address those biomechanical problems. And you can see that the foot is severely pronated, okay, especially the left foot where there is the ulcer. And so we use foot pressure mapping to see how we can obtain a functional assessment. Okay, we need to determine how the function of the foot may be linked to the plantar pressure, and we need to determine the impact of pressure on the area of interest, and whether the treatment that we are going to prescribe, most of the time, if the patient is high risk or if the patient has an ulcer, whether it will be successful in reducing the pressure in the area. And technologies indicated for this condition include pressure mapping, among others. And pressure mapping technology, there are two main types. One is a platform-based and one is issue-based. So here we see a platform, which is basically an array of sensors where the patient can walk over it, as you can see with this video. And there are many methods when using this apparatus. Obviously, it has its limitation. For example, our patients do not walk barefoot, hopefully. But it's very important that the method that is used to collect the data is correctly done. So this is the ulcer I was talking about under the first MPJ of the left foot. Issue pressure mapping allows us to look inside the shoe now, and basically it will tell us how the footwear itself, how the different type of shoe is affecting the pressure, is affecting the patient's foot, okay? And also whether any devices that we put in there can be effective or not. And there are mainly two types of pressure technologies. One we call capacitive technology, which means that the sensors are basically little capacitors that store electricity in them and give a value when they are pressed, whilst the other is resistive technology. And this is an example of an issue sensor. This particular sensor has 960 sensors, and it is flexible, and it can be cut to size. So basically it can be inserted into the patient's shoe, and it will give us a lot of information. And this information can really help us in order to determine whether specifically our treatment modality is effective or not, is going to be effective or not. It's like when the patient goes to a physician, he's being given a particular treatment, but then the physician will check whether that treatment is being is being effective or not by doing any type of relevant tests. I like to use this as an example, okay, how foot pressure mapping technology can be applied. So here we are looking at that patient's area where she has the ulcer, and we can see that she has a pressure of over 700 kilopascals, and that's a lot of pressure. Okay, guidelines nowadays say that about 300, anyone with above 300 kilopascals should be dealt with. We should manage these persons. So basically, 700 kilopascals was definitely a huge amount of pressure. So what we did was we designed an offloading insole for this patient, and as you can see there, we managed to bring it down by over 200 kilopascals, which is quite significant. Okay, but applying the biomechanical concepts that we know, since the patient had a very pronated foot, when we added a medial heel post to correct the posture of the foot, just because the patient's subtalar joint motion allowed us to do that, we actually managed to reduce it even more. So my argument here is, if we hadn't checked, we wouldn't have known how to get the pressure reduction more effective. And I think that this modality is highly underused. And nowadays, it's not used so much in clinical practice, unfortunately. Why? Well, first of all, it's expensive. Such a system will cost anything about from 10 to 15,000 euros. Also, it requires high expertise to use and interpret, okay? And it takes a long time per patient. So it will take 1 hour at least to prepare the patient, have the patient, walk up and down, analyze the data, analyze it correctly, and all that. So basically, as a result of this, I think very few centers do use this. And I think it's very important to assess the effectiveness of my offloading, because I cannot wait for clinical science, because to see differences in clinically, it will take time. And the longer the time it takes for the ulcer to heal, the more chances there are of the patient getting infection, for example. So what we did, we tried to do something about it. So we designed a single sensor pressure and temperature measurement system. So the idea here is that, okay, so I have a patient with an ulcer in a particular area of the foot. What data am I interested in? Obviously, the data I'm interested in is the amount of pressure under the ulcer. Okay? So basically what we did is we designed a system which is very simple to use. We designed a unique sensor which measures both temperature and pressure at the same time, because we have done some studies in the past and we came up with what we call the thermopressure concept, where we realized that patients with diabetes and complications, the more the pressure increases, the more the temperature increases. And I think using those two parameters, knowing that before ulceration occurs, there's going to be a local inflammation, okay? So the temperature is likely to rise. We designed this sensor to do two parameters at the same time. However, this simple tool makes it easy for any clinician to measure that area in less than 5 minutes. So basically, this is just a simple, and I can show it to you here. It's just a simple box which attaches to the side of the shoe. It just has one on-off switch and the USB sensor just for charging. And then through a mobile application, it will gather data and it will take just a few minutes to do this. And this is the type of data that it will give us. So we can see pressure, how it alters with every step. And we see the temperature slowly rising as the patient is spending more and more time wearing, using that sensor. And it's very simple data because it's the data what we really mean. So it will give us where we put that sensor. In this case, for example, like under the third MPJ, it will give us the peak pressure, how much the peak pressure, so that I can take a baseline measurement. It will give us the minimum pressure. It will give us the mean pressure, okay? And also the same things for the temperature. So basically the idea would be to get a baseline data of the amount of pressure under that area, put in an offloading device, do the test again, and see if you have succeeded in reducing the amount of pressure as much as you want, which nowadays, according to guidelines, to international guidelines, should be about a 30% reduction. And we feel that we're very confident and we're very excited with this because it is not just those few who are lucky enough to buy the expensive foot pressure mapping systems that can now analyze and have real objective data instead of just maybe we did this, maybe we did that. So does it work? Is it effective in clinical practice? And one of our PhD students has just finished a study, which was a matched parallel prospective experimental trial. So basically, we recruited 88 adults living with type 2 diabetes with a past history of foot ulceration. So we know that these are very high-risk patients, okay? And they were prescribed prescription orthosis by the local hospital. So all these 88 adults had an offloading device given to them by the hospital. Besides this, they continue to do their regular standard treatment. So we divided them into two groups. In one group received standard care, so they were using the offloading device and standard care, while in group two were assessed with this device, and wherever we saw that the device was not working correctly, we adjusted the offloading device so that it would give us that reduction of 30%. Well, just to tell you one thing, just to know that 45% on the initial visit, 45% of these patients had an incorrect offloading device, or basically the offloading device given to them by the hospital was not doing what it was supposed to do. So they were monitored every 4 months for a period of 1 year. And after 1 year, if you'd like to see the results, so these were the number of ulcers we had in our experimental group, okay? Out of 44 high-risk patients who had a history of ulceration, who started off with no ulcers, after 1 year, we had 2 patients who had an ulcer in the neuropathic group. But those who we did not monitor, well, it was a much different picture, because we had 3, 4, 5, we had 10 ulcers and 4 amputations in that group. So I think this clearly demonstrates the useful of such a simple device, of such a simple test that can be done in 5 minutes, because I don't feel that our patients are being managed correctly, because they are not being assessed regularly for foot pressure mapping, and to see if the devices, the offloading insoles device, whatever they have been given, are being effective or not. So to conclude, I mean, it clearly shows, this research clearly shows that the careful monitoring of foot pressure at sites of risk of ulceration can improve patient outcomes. And so we need to look at this condition from a novel view so that we can really help to reduce ulceration and ultimately amputation, which is, at the end of the day, why we're here. Thank you.